All right, everyone. Assalamu alaikum. Good evening. It's me, Kuratolan, a clinical psychologist and interpersonal therapist. Today, we were scheduled to discuss a lecture in our ongoing course of a clinical course in treatment management in psychopathology. Today, we are going to cover a topic of depressive disorders. Particularly, we will be talking about a major depressive disorder. All right. When we are discussing about depressive disorders, or when we are talking about the framework of the depression or depressive disorders, it actually include a variety of disorders. All right. According to the DSM-5, these are the particular list of the disorders that is actually included in the depressive disorders. When we are talking about depressive disorders, it actually means those kind of disorders or disturbances where a person actually lies beneath the continuum or to the bottom edge of the emotional scale. All right. So, in case of depression, when we are talking about major depressive disorder, it actually manifests itself or being called as the depression. It actually means a problem where actually the symptoms or the concerned problem has been manifesting itself from a particular days, all right, from a very particular duration. Okay. So as we all know, DSM-5 or DSM-5 GR are not the first manual for the diagnostic purpose. Apart from that, we had DSM-4 TR, DSM-4, DSM-3. So these are the two particular new diagnoses being included in the DSM-5. It includes, um, all right, let me just, all right, let me just handle it out again. Okay. All right, just let me know if it's still not visible for you guys. Okay. Unfortunately, there is something going on, but we are not able to identify it so well. All right. Okay. Is it visible till now? Because here I have been notified that it's going on, but I don't know what's happening right now. All right. It means someone have bugged into my system today. Okay, unfortunately, students, I don't know what's happening right now, and still the problem is not being so well. So I think we are going to have to compromise on today's lecture, and I'll upload it there, and you people guys can just, you know, learn it from there. Is it still not visible for you guys? Because I think it's visible now, right? Oh, thank God. Okay, so all right, let's just get back to the track. So we were talking about the variations in the diagnostic manual we have been reading till today. We now have two other diagnoses in the continuum or the framework of the depressive disorders that include the disruptive mood dysregulation disorder and premenstrual dysphoric disorder. All right, I have included the changes that have been particularly made in the depressive disorders till today. All right, when we are normally talking about depressive disorders or the major depressive disorder, normally students have been asked in the vivas or the exams or during the interviews that what's the difference in bereavement or the depressive disorder itself? Is there any kind of difference? Then yes, bereavement is particularly different phenomena than depressive disorder itself. All right. In case of bereavement, you are actually being concerned about um, loss of some loved one. Okay. And that particular loss is particularly related about a person that have been very precious to someone, and the particularly the duration, or you can say the prominent effect of that duration is on the feeling of emptiness and loss. All right, I can say that during bereavement or the grieving period, a person is actually going through um, preserved self-esteem. All right, because during the major depressive episode, a person would be feeling um, worthless. He would be having some kind of feelings like self-loathing or self-hatred. That's very common framework of the depression, right? I'm not talking about the diagnostic manual right now. I'm talking about the definition of the depressive itself. So when we are talking about the bereavement, we are basically talking about loss of someone that is actually causing an emotional disruption in the person and leading towards the feeling of emptiness or the loss. All right, which actually can create itself as a willness or thinking about dying, or thoughts to end itself or join the deceased one. Just for the purpose to join the deceased one is bereavement. It's not depressive disorder, major depressive disorder. All right. I hope I have cleared this definition in a very well mannered. So let's just continue towards our next criteria. Okay. So bereavement is your psychosocial stressor. All right. But depression is a bit different. Right? Bereavement related depression is obviously a very different kind of scenario, because a person will be implying to end himself because of the emotional disruption or the emotional loss. All right. But bereavement is basically to join that deceased one. Okay. All right. So we have discussed about the bereavement and the depression, the basic difference among them. So what's depressive disruptive mood dysregulation disorder? All right, Disruptive mood dysregulation disorder was actually created to address the problems in early adolescence. All right, those particular individuals at the age of 11 to 17 to 18 years, they have a very different kind of attitude. Okay, they normally would be feeling like kind of irritable, aggressive. Okay, they would be having the tempered outbursts. All right, that can obviously sometimes verbally, sometimes behaviorally, and towards the destruction of some kind of property or the people. Okay, but that destruction is very inconsistent with their developmental period. So in case of disruptive mood dysregulation disorder, if a child is the um, younger than the particular age for the depression, okay, then you have to consider the disruptive mood dysregulation disorder, particularly for the children. All right. So here it comes. Then what is persistent depressive disorder? Normally we used to listen dysthymia. So what actually it is? What's the difference in the major depressive disorder and the persistent depressive disorder? The basic difference between these two are their presentation, time, duration. All right. In case of major depressive disorder, an episode should be persistent for at least 2 weeks. Okay. But in case of persistent depressive disorder, that episode would be persistent over the period of time for like a year or 2 years. All right. So it actually demands a long-term episode. All right. So now we are moving toward our basic, you can say the topic, that is a major depressive disorder. When we are talking about a major depressive disorder, first of all, we have to understand what are the requirements or what are the diagnostic criteria for the major depressive disorder in the DSM-5. All right. In DSM-5, we have a continuum, or you can say we have a bridge to learn about the major depressive disorder. That is, 5 or more of the following symptoms should be present for at least 2 weeks, all right, to represent the change in their previous functioning. All right, if a person was very vigilant, very energetic, prior to the episode, now he would be very distressed. He would be very lacking towards their activities. All right. So that's the difference. Okay. So either he would be having a depressed mood or loss of interest or pleasure. Okay. So what are those 5 symptoms that are being concerned here? Depressed mood for most of the time in the day. All right. Second, remarkably diminished interest or the concern toward their most activities of their daily life. All right. Third one is significant weight loss, or you can say loss of appetite and the very rigorous eating. Sometimes people eat too much in depression. All right. So any kind of change in an appetite for like nearly every day is being concerned here. The fourth one is insomnia or hypersomnia, or you can say the change of phenomena of sleep in them, in that particular person, is another symptom to be included in depression. Psychomotor agitation. What is psychomotor agitation or retardation? Psychomotor mean any kind of phenomena that can lead to the change in the motor functioning of the individual. All right, that can be agitation. Agitation means hyperactivity, hyper responsiveness. Or retardation means lack of activity. All right, and that can be very observable or very subjective towards the others. All right, so fatigue or loss of energy, being restless. All right, feeling worthless, hopeless. All right, inappropriate guilt, or being delusional sometimes. Sometimes student would be asking me that why sometimes depression or the patient with the depression actually have some kind of delusion as well. So this is the basic reason, all right? Because delusion sometimes can become the presentation for the depression itself because of the long-term inappropriate guilt toward their own self. So delusions can manifest them lately. Okay. So another symptom include the diminished activity to think or concentrate, being indecisive, or you can say their problem-solving skills are being very much effective right now. Okay. So recurring thoughts of death, suicidal thoughts, suicidal ideation sometimes being sometimes even the individual can have a suicidal attempt as well. All right. So another criteria is these all this kind of framework should not be very much explained by any other kind of medical condition or psychological condition. So another one is that these kind of problems are actually causing a very significant distress or impairment in the individual's daily life functioning. All right. So this was all about the DSM we have discussed. All right. So here comes another point. Then if a depression is this kind of problem, is it that kind of problem that would be having some kind of physical effects on someone's life? Yes, of course, because depression is actually your response toward a significant loss. All right. It can include your intense sadness, your rumination about the loss. So that's very normal to have a financial loss, or the loss in some kind of facing like some kind of natural disasters. So sometimes it happens. All right. So the decision inevitably requires the exercise of clinical judgment based on the individual's history. All right. For diagnosing any kind of psychological problem, you have to be sure about your clinical assessment as well as your judgment. Your clinical interview is very important to diagnose a person, right? For any kind of psychological problem, especially the depression. All right. So the last criteria here have been mentioned that the person should not be having or have no kind of history about the manic or the hypomanic episode. All right. So why? Why is it being included here? Because we would be talking lately that if a person have a history of manic or hypomanic episode, then we would be including that particular diagnosis towards the bipolar disorders. All right, that would depend about what kind of history that person was having lately. All right. So that is regarding the coding or the recording the diagnosis for the depressive disorder. Okay, so in case of diagnosing the depressive disorder or major depressive disorder, that is the particular course or specifier, all right, that is regarding the severity of the problem, all right, that would depend on purposefully on your diagnostic tool as well as the number of episodes the currently patient is having, his rumination period, his remission period right now. So that whole would be responsible to calculate the behavioral issues as well as diagnosis of the person. So how would you record the diagnosis for the depression? First of all, you will write the code of the DSM regarding that particular problem. All right. So, what is about the code? If a person is having a mild problem with a single episode, it's his first episode, then the code would be this one. This is the DSM code, and this one would be the ICD code for that. All right. If a person was having a mild episode or severity level is very much mild, but he was having a recurrent episode, then the code would be this one with the ICD code, this one. This as a professional manner to present a diagnosis, all right? So you would next write the major depressive disorder, then the episode, is it single or the recurrent, level of severity, if the patient was having a psychotic episode or not, and a remission specifier, is he was having a kind of remission or it was a new kind of problem. All right, that would depend on the history of the problem. So here are some other specifiers you can mention lately. That is, was he actually having an additional changes in himself, like with anxious distress, the problems was having a mixed feature or atypical features. Atypical features actually mean the client is having a depression. You are very much sure about it. But the typical presentation of depression is actually not being very much met there. All right. So these are the with catatonia or without catatonia. Peripartum onset is basically regarding the females. Seasonal patterns. Sometimes client would report that he is having this kind of a problem lately in normally in the winter season. So you have to be concerned about the seasonal effect there. All right. We have talked about the depression. So how to treat depression? First of all, being psychologist or being psychiatrist or the neuro consultants, we all have to be sure about did the client's psychological problem or the psychological changes, or you can say the brain phenomena has been completely covered. All right. For this purpose, you have to make sure that the client have a fully functional psychopharmacology, or you can say adherence towards the medication. So, what are the particular medications for the depression? First of all, we normally used to call it antidepressants. Antidepressants itself have those particular group of medications, or you can say the drugs for the treatment of depression. That first include monoamine oxidase inhibitor, MAOIs, then tricyclic antidepressants, that are the TCAs, then selective serotonin reuptake inhibitors, SSRIs, then selective noradrenaline reuptake inhibitors, that are called SNRIs, serotonin receptor agonists, are SRAs. So why are we discussing psychopharmacology for the depression? You have to understand one thing, that if there is any kind of psychological problem which have a very much related content, normally a psychological problem have a related content of cognition or emotion, then you have to be sure that there is something going on in the brain as well. All right. So the change in either the neurotransmitter or the chemical function, or any physiological change in the brain, can be the reason of any kind of psychological problem. So, to cover that up, or to actually regulate that particular change, you have to be sure about the psychopharmacology. All right. So here, I hope you would have understand that these are the particular neurotransmitters that are being held responsible for the depression, that first include the monoamines, then include the serotonin, then noradrenaline. So these are the particular neurotransmitters which are being said responsible, that their overdose or their over secretion in the brain can lead towards the depression itself. All right. So we have those particular drugs which inhibits the phenomena or the over secretion to compensate their effect. All right. So what are MAOIs? What are the basic MAOIs we have right now? That includes the phenelzine, isocarboxide, and phenylcryptamides. All right. Then TCAs normally include the amylin, salsivol, normally is being practiced in Pakistan and South Asia. Another one is imipramine. It normally comes with the name of a tofranil in here. Then trimipramine and clomipramine. Clomipramine normally being found clomipramine, and these are the normal drugs that are being practiced here. All right. In case if it's about the serotonin reuptake inhibitors, you have to be sure that these are the particular drugs or the medicational groups that are being responsible for that. It includes the fluoxetine that is normally come with the name of Prozac, then Favorine, Cirozet, Zoloft, Cipram, or Cipraflex. All right. Cipraflex is actually a better version for the Cipram. All right. Then here comes an SNRIs. What are the SNRIs? All right. These are basically the combination of inhibitors to basically deal with the serotonin and norepinephrine. Okay. So what are they? They normally include the Effoxer and Cymbalta. Okay. Okay, then comes the atypical drugs. Atypical drugs are those drugs which are basically for the depression, but the mechanism is a bit different. They are not inhibitors, they are agonists. All right. They promote the secretion of that particular neurotransmitter or the chemical in the brain. Okay. So they include trazodone, that normally comes with the name of Dapril, then bupropion, or mirtazapine. Okay. We have discussed about the basic phenomena of depression. We have talked about behavioral or normal behavioral manifestation of depression. We have understood the difference in bereavement, grief, and depression. All right. We have talked about the depression in the childhood as well as depression for the um, grown up individual, right? We have discussed about the disruptive mood dysregulation disorder, right? We have talked about psychopharmacology or normally prescribed medications for the depression. Now we would be talking about our part in the treatment of depression, right? First of all, you have to understand what are the psychological evaluations or psychometric evaluations that are being prepared or available for the diagnosis of depression. These are the tools, or you can say the diagnostic tools being present here in the day for diagnosing the depression. That includes the Beck Depression Inventory, then EQSD. EQSD was basically used to understand the quality of life for a person in 5 dimensions. I have mentioned here, and his you can say its two versions are being prepared till now, one for the adults and one for the adolescents or the children, and it's being now widely being practiced in different languages worldwide. All right. Then comes the Hamilton Depressive Rating Scale. Then come the Montgomery Asperger Depression Rating Scale. That is not being practiced in the South Asia, but worldwide, yes, it's being practiced lately. Then comes this evaluation for the children, or you can say the individuals that are prior to the age of 18, right? So, what about them? Are they having any particular tools to diagnose depression in them lately? Or obviously the disruptive mood dysregulation disorder for them? Yes, we have. First of all, that includes the behavior assessment system for the uh, children, that is normally called the BASC. Then comes the Children Depression Inventory or Children's Depression Rating Scale, right? Then we have another scale for that purpose, that is the Quick Inventory of Depression Symptomology Self-Report. That's normally used for the individual who is a bit educated, who knows how to write or respond very well, and to read, of course, because it's a self-report inventory. Then comes this life satisfaction index. Life satisfaction index is normally being practiced by the healthcare practitioners for just a relative diagnosis in case. All right. So, what are the therapies or the major therapies that are being practiced for the depression itself, or that can be practiced for the depression? First of all, as we all know, we have been taught lately cognitive behavior therapy, right? But just to be sure, cognitive behavior therapy for depression is a far more different than a typical cognitive behavioral therapy. It's very much complex for CBT for schizophrenic or for bipolar and for the depression. All right, it's totally different in all these three kind of scenarios. Another one is DPT. In case of dialectic behavior therapy, basically it's a typical combination, or you can say a mixture of cognitive behavior therapy along the mindfulness techniques or the Gestalt therapy itself, all right, to regulate a person's emotions that have been disturbed lately, right? The third one that is being practiced is mind body integration. We all know in case of depression, a person is having a kind of scenario or experience that is not being very much held with his mind. That's why he's being disturbed lately, right? So this is a very much better practice for this kind of problem. Then comes the interpersonal therapy. Always remember, interpersonal therapy is about regulating the conflicts or the problems among the relationships. All right. So we are aware of this. That's in case of depression, obviously the person would be having some kind of significant problem in its daily life, right? So in his daily life, it also includes his relationship issues, right? So that kind of issues can be dealt with interpersonal therapy very well. And obviously that can lead to a very much good effects. Then comes the timeline therapy. In case if it's about an unresolved conflict of the childhood or the past memories, and it's causing the guilt and it's causing the depression, then you can use timeline therapy to resolute and regulate the individual's memory and its conflicts. You can make him go through that and move forward. All right. Then comes the gratitude practice. Gratitude is basically, you can say, a practice that have been actually extracted from the spiritual psychology, or sometimes it's being said that it's about the positive psychology. So, when you keep smiling, your body will perceive that you are doing good. Okay. And over the period of time, you would like feeling better. So, same like that, in case of gratitude, if you would be very much having, the best perception of the world, or, you are being practicing about it. So the mind would also perceive that it's all going very good, right? I'm at very good position. I can do a far more better than this. If I can do this, then obviously I can do this, all right? So this practice of gratitude can lead towards bottom to the edge, or you can say bottom to the upper side or the forward side, okay? So it's being very much practiced lately. These are the particular techniques you can use in case of depression for the patient. That includes the relaxation techniques and sometimes the PMR. Then you can give him the thought diary, or you can work on their cognitive structure reconstruction if a person is now emotionally doing good. Then you can start the CBT or any other kind of behavioral therapy. All right. First, you have to make sure he is adhering towards the medication. Secondly, he is being relaxed. Thirdly, his psychological phenomena is now at the place. Okay. Then you can work on his behavior. Then you have to move towards the cognition lately. Okay. So these are the particular things you can actually work on. That includes the mood monitoring chart, a downward arrow technique, cognitive restructuring, thought evaluation sheet. But always remember, in case of CBT, we are being practicing thoughts evaluation sheet very much. But always be sure that never give a column of evidence for and against in this sheet for case of depression. Never do this. It's a huge mistake in the practice. Because in case of depression, a person is in distress. Obviously, he will give far more evidences to support his delusion, to support his distress. Okay. So, for this reason, it's always been said to never use evidence for and against column for this kind of sheet. Okay. Then you can work on developing their alternative perspective. You can work on their coping strategies. You can, work on their diet, their sleep. Obviously, that is being very much disturbed. So you can work on their physiological phenomena. All right. So we have discussed about it. Now, for your kind of understanding and better review, I have selected a case for you guys. Uh, Here she was my patient. She was basically 37 years old, a female, and she was actually transferred to me around 2 years ago uh, with a complaint of, um, you know, I hope it's very much easy for the students who are very much aware of Urdu. But in case of students from the abroad background, let me translate it for you. Okay. The patient is having disturbed sleep. She can't sleep very well from the last 2 weeks. Episode of agitation or aggression, having a very much warmth feeling lately from the last 3 weeks. Complaints of headache and loss of appetite from last 3 weeks. She cried a lot without being any much concerned thing, and stays a bit low. All right, from the last 3 weeks. Sometimes she got episode of syncope from the last 3 weeks, and have a very much childish behavior sometimes. Okay. For this purpose, the investigations that are being conducted on my side that included a clinical interview to collect all kind of information lately, then Bander's Gestalt test. We have discussed in our previous lectures that we have to make sure the problem is not neuropsychological. Neurophysiological phenomena should be overruled first, right? So for that purpose, and to identify the emotional indicators as well, you can use Bender Gestalt test. Okay. Then, for some particular reason, I used a human figure drawing. Then Rotter's incomplete sentence black test because she was not able enough to proceed with the human figure drawing at that moment. Then standard progressive matrices, that is an idealistic approach in case of hospitalized setting, basically to identify the abstract knowledge of the person. And obviously the diagnostic test, Bander's back depression inventory. Okay. So if I have to talk about her history, the history included that she is being having loss of consciousness or episode of syncope from like 2 to 3 episodes a day, and it's been happening from last 3 weeks. All right. Having low mood, loss of sleep, loss of appetite, excessive crying, loss of energy. Okay. And she didn't obey towards her brother. All right. And but she didn't have any kind of suicidal ideations. Okay. Let me get it straight for you guys. Let me revise it for you. Okay. When we had studied about the depression, we didn't say that a person should have a recurrent thought of that, or he should have a suicidal ideation. We had learned that five or more of the following symptoms should be present. And one of those symptoms included suicidal ideations, right? So, okay, it's, I think, happening again. Anyways, let me just describe that case for you guys. She was actually having very much problem, all right? But why did I use the human figure drawing? The reason was that she had this problem for last 2 years, and that was actually her recurrent episode. Okay, but due to the overdue of the problem, she became so weak that at that moment she was brought to me on the wheelchair. All right, she was totally bedridden. Okay, so she was not able to eat anything, she was not concerned about it, and I have to work on her appetite at the very first stage. Okay, so for that reason I have to make sure that her assessment should not be self-reported. Okay, so for that reason we use human figure drawing to make her less work about it, less tired. Okay. So, when we went through her history, we understood that actually she was having some major conflicts with her mother in her childhood. All right. And for that reason, her problem was being manifesting itself lately. Okay. She was very good at her job. She was a computer teacher. She was teaching very well. But due to her breakup of her engagement, the stimulus became the trigger, and actually it happened. All right, so for that reason, as we had discussed lately about the management of the depression, the concerned techniques were used. I hope it was very much understanding for you guys. So this was for the day. If you have any kind of question, do let me know. All right. All right, anyone, any question? No one have any question today. Am I being a very good teacher? All right, then. Let's just continue towards the case. Okay. So there was no significant predisposing factors, right? And she was doing well. She was determined, and her problem started when she was in the grade 9. All right. But the protective factors were also found. She had a bit support from her mother and from her elder brother, right, to make her feel safe. All right. But her problem started when her husband died and her recent engagement was being off lately. And that became the reason that she got so disturbed, right? So sometimes actually the problem is not about in the relationships, or you can say it's not in the person itself, it's around itself. All right, it's in the surrounding. Sometimes I say that treatment actually is not working because medication is not being placed on its right place. Okay, sometimes individual needs your listening. Sometimes individual needs your support. Sometimes he just wants someone to be there. Okay. So whenever you are dealing with a patient having any psychological problem, always be very concerned about your words. Okay. About your communication style, about your language. If the patient is speaking in Punjabi, or typically in, you can say, the typical English or native English, just to be sure about it, to actually make him feel safe, make him feel normal at that moment, right? Because it's very much important to build a rapport first, all right? There are a lot of people to judge outside. There is actually a lot of words to make them suggest something, make them feel like it's nothing bad going on. All right. So let's come back to the case. Her husband died, her engagement break off, and her teeth started clenching at that time, 2 years ago when her husband died. All right. So she started having an episode 3 times a day, and she stopped her social gathering. She stopped the social interaction. All right. So this was the basic medication that was being prescribed. That include Prolexa. We had discussed about it, and Nazi. That is a typical atypical antipsychotic, right? So her menstrual history was found normal, so it was not about the premenstrual depressive syndrome. She was living in a nuclear family and all that. This is her whole history. Okay, this was her evaluation where it was found that her percentiles was average in the Bander's Gestalt test, but her emotional indicators found that actually she is having a clear-cut features for the depressive disorder. Organic features also indicated that there is something going on. There was organic impairment lately. All right. In case of human figure drawing, basically due to her lack of you can say the social gathering, and sometimes due to the lack of her attention and her physical health, we made sure that she do very less by herself, right? But her human figure drawing also showed that she was having a depression stuck in her past life, and her anxiety was all about potential risk, right? She was actually not moved out of that phase. Okay. It was a very much clear indicator in her human figure drawing that she was actually being desired to return to her, the childhood life. All right. So when we applied the Rotler's incomplete sentence blank test, we clearly found that she was having a very much negative manipulation about the relationships. Okay, and we also broadcasted that the adjustment problems are actually regarding her current issues. Okay, regarding her social relationships. So it was also being held that way. Then, for the purpose of diagnostic reasons, due to the availability purpose, we had a Bender Gestalt, Beck depression inventory. So we used it and we found moderate severity level. Okay. So for that reason, it was being cleared about it. Her observation included that she was very confident, she was very intact in her speech, but she was very irritated lately. And she maintained her eye contact. She had a very much awareness about her orientation. All right, she was very cooperative towards me. Her perception was intact. There was no somatic complaint going on. Okay. She was very conscious, very attentive, very coherent, and her, cooperative. Sometimes she becomes shy in case if there is someone else listening. Okay. But later she opened herself to me. There was no hallucination or delusion going on. She had a very much um, intact short-term and long-term memory. There were no suicidal ideations present. Her abstract knowledge was also good. Okay. So We even differentiated her functional level prior to the problem and nowadays. Her functioning were normal, but she is being always aggressive and stubborn in nature after her husband's death, and now she is being introvert, right? So this is the change. Her diagnosis has been mentioned here as, like, I have let you guys how to write this pacifiers in case of depression. Okay, so and this is all about her prognosis. She had a better treatment compliance, a very good support system, and due to her pre-morbid functioning, it was found that she might be having a very good prognosis. All right. So what we actually did with her, what was the treatment, or you can say the basic therapeutic techniques we use. So these were all the things we used lately with her. All right. Letter to the problem as friend was actually, you can say, a very wonderful practice in case of depression, because you are actually writing to yourself. You are actually, kind of like chair to chair talk with yourself, one to one. It's very much resolutory. Okay, so these were all the things we practiced with her, and she found herself very good lately. In case you are not able to understand or formalize the case, here is the picture for you guys. Let me make it a bit visible for you. All right, here is the picture. Predisposing factors included um, okay. Predisposing factors included her emotional sensitivity from the childhood, her you can say her amnesia in her grandparents, and then she was vulnerable to harm. She had a lack of social support due to being, dark in color at her college. She was being discriminated at that moment. She even faced a lot during the college time. Then the precipitating factors included hyperactivity, hyperresponse, then non-compliance with the family, postpartum depression after her abortion with her first husband. Then recently, then her husband died in a car accident in America, and she was not even able to watch him at the last moment. Then the perpetuating factors include her previous diagnosis of depression by that particular doctor at that moment in America. Then criticism from the family for having no children, then poor coping method, revisit to her in-laws, her previous in-laws, all right. Then those were the presenting complaints we found, right? This is the case conceptualization. All right, always remember one thing. In case if you are having any kind of case, you have to be sure that you have conceptualized the model of your patient. What actually going on, you have conceptualized it. You not only have memorized the formulation of the problem, how did that problem actually begin, you have actually found a theoretical ground to understand that. For example, we found that this client's case was actually based on the back depression model, all right, because it was very much related to the client's symptom and her illness, all right. Her dysfunctional negative view on about herself, her view about the world and the others, and the negative life experiences made her go through that, and her physical health also became a very much a testimony for that. All right. So this led to dysfunctional assumptions that I'm not good enough, or nobody cares about me, or people are, rubbish, etc. Those were all activated in herself. Those were the cognitive schemas that got activated, right? So which actually result in her emotional and the behavioral symptoms and cognitive as well. All right. So this was the whole class for the day. My apologies again for that disturbance earlier. So take care of yourselves and remember, mean your prayers. And in case if you have any kind of question, you can mention me in my YouTube channel to respond you well. That is the Science of Psychology. Make sure to like, share, and subscribe it to stay updated and stay tuned with me. Thank you. Have a great time ahead.